Series. This is Roger Glass. I look forward to hearing the presentation.
AFREhealth webinar. We are really excited to focus for this webinar on contact tracing, screening, and as we move to community and most of African countries easing their lockdown, I think this is a really timely topic. We have a really exciting panel speaker. My name again is Nachega. I am a professor of medicine at Stellenbosch University. And my co-moderator, I'm gonna let her present herself, Fatima.
Hi, good afternoon, everyone. My name is Fatima Suleman. I'm actually a professor in pharmacy at the University of KwaZulu Natal in Durban, South Africa. I'd like to welcome you all to this afternoon's webinar, and I look forward to some engaging discussions.
Yeah. So without further ado, yes, we have a very heavy agenda. Our first speaker is Dr. Ashraf Grimwood. I cannot make justice introducing him, so he's gonna introduce himself. Ashraf.
Hello, good afternoon, everybody. Thanks, John. Thanks, Fatima, for inviting us to do this presentation. Yeah, so I'm a medical officer. I work as the CEO of Kheth'Impilo, and I've been working in HIV for a long time, and this is reminds me so much of all the work that we've been doing. I call this HIV on steroids. Anyway, so yeah, so with this, so I'm responsible to talk about community screening strategies, and just like to remind everybody of a statement that was made a few days ago by Michael Ryan, the Chief Executive Director of WHO, and basically saying that shoe leather contact tracing cannot be ignored. And that really takes us right back to basics, that we need a public health workforce that is going to be needed to do the tracing, the testing, the isolation, and the quarantining. The IT tools that we use cannot replace this, nor can high-tech tools make it a huge difference of, except enhancing modern contact that we can use today. So our community screening happened a few weeks ago. Kheth'Impilo had been employing community health workers to help with HIV testing and TB screening, as well as home-based care and the delivery of drugs called chronic dispensing units. So we were seconded to start community-based COVID screening in partnership with the Western Cape Department of Health. And here we had designated areas as determined by the Department of Health, where we were doing door-to-door screening of all household members within a designated area. The National Department of Health had asked that 25 households be screened per day, but with the Western Cape approach, they've been using the polygon method, where they have a targeted screening approach focusing on cases that are confirmed. And there is a small layer below that where screening is undertaken of a cluster of homes. So that's one of the approaches. The other approach is a cluster screening, where if there is a shopping center or a taxi rank supermarket where cases have been identified or there have been possible contacts, that area then is screened. And the methodology is healthcare workers go door to door, ask every individual in that household the 4 questions, which I'll show you just now, of symptoms used. And those who are positive in answering one or more of those symptoms are then referred to the health facilities for SARS-CoV-2 testing, where they are again checked for symptoms, their temperatures checked before they are tested. Those who are ill are referred onto the clinic. Those with mild symptoms are sent home to quarantine until results are obtained. And then patients are informed as the outcomes. And those who are positive are isolated at home or isolated in at areas that have been determined by the Department of Health. And Dr. Hassan will be talking more about that later. So this is just an example of the approach. As you can see, the red dot on the screen on the left-hand side, in the blue polygon, that's the case. And then this is just the roadmap. These are the community healthcare workers who are leaving a facility in the background in the far left, and then walking and then going door to door. So the training that has happened, so we noticed that there was this trend in COVID cases increasing, and we felt that it was critical that our staff be trained and informed about COVID-19, because it was just a matter of when cases will be landing in Cape Town. And so we started in February already informing our staff, and that soon increased when we were asked to help the Western Cape Department of Health, and there we were asked to provide training on the appropriate use of personal protection, protective equipment, protection of staff and others, cough etiquette, hand sanitizing, and also the correct use and application of bleach for cleaning surfaces. This was complemented by the Department of Health and PEPFAR providing screening tools, pamphlets, t-shirts, caps, sanitizers, etc., to facilitate the process. Of value was also the ongoing input from Department of Health on PPE training, especially before and after a screening output in the communities. And this would be useful where certain issues would be aired and addressed. So, we continue to provide updates for staff, because as with HIV, things are changing very rapidly. And especially in regards to what to wear, where to wear it. And now with level 4, there's also extra conditions, and staff need to be made familiar about these. So we have now instituted self-screening of staff before they start work, and anyone who scores positive does not go to work, but then is recommended to go for testing. We also have a policy brief now, of COVID-19 policy brief, where and staff are expected to become familiar with what this means in the workplace. And this is just an example of the training with the physical distancing, especially when you're trying to get information out to a large number of people. Yes, you can inform people electronically or with social platforming, but sometimes it's really important to just get people to interact and to ask questions and to address fears. These are just some of the training tools, training and screening tools, as you can see on the left, what WHO has put out. In the middle is what Department of Health has guided us on, the questions, cough, sore throat, etc., shortness of breath and fever. And then on the right-hand side is what we at Kheth'Impilo ask our staff to report on a daily basis. This is on their phones, and this is being very, very useful in guiding us on who needs to go for testing and where we are with our over 200 community care workers in the field. As an example of the work they've done, this is just a screen with bar graph showing the number of cases screened, and over the few weeks of April, our staff screened over 13,000. The positivity rate's quite low, at about 13%. Unfortunately, the gender and age has not been shown here, and we are now trying to collect this data so we have better understanding and granularity as to where cases are and what the yield is when it comes to the numbers who are screened as positive. And we have recognized that children are not being picked up as often as they should be. So just touching on some of the challenges that we've come across. At the beginning, at the start of the screening, there was a high level of anxiety amongst the staff, especially in regards to their own personal risk to infection, based on all the video, the television coverage of cases in Italy and in Spain, and also anxiety within their households. And this was allayed through just really ongoing education. The other problems we're finding is the long-term turnaround time of PCR results for staff who are in contact or symptomatic, and this does create anxiety. It also presents challenges when it comes to managing staff in the field. A very interesting experience has been something which was discussed in the 1918 epidemic, where you get the rise of xenophobia, rejection, racism experienced by some community healthcare workers, where there's a clashing of cultures, language barriers experienced within some of the communities where language is not shared. And that's why we've always tried to keep community care workers from the area working in the areas. And then also the concern where communities have rejected screening and also rejected the testing based on their fear that the swabs are contaminated. And then also with staff walking around with some of the PPE, that has also created some form of stigmatization. And we've tried to manage that now. It's much better now as people have become used to these the COVID-19 pandemic. So the other challenges are accessing homes where people are disabled, those who are bedridden and unable to be mobilized, especially when there's no adequate personal protection for those who handle the contact. Then also the space situation, and in some of these houses, very tight. And then also our key populations, commercial sex workers, etc. Other hard to reach populations include the homeless and those living on the streets, and men on the road and shift workers. And then certainly the lack of security where people struggle to access food and services has put our staff at risk. So some of the solutions, just quickly, certainly we find that communication to communities, which needs to be ongoing, it needs to be basic in local languages, it has to use multiple platforms, multiple layers with regular updates is really critical. And then we certainly need authoritative voices to deal with the daily onslaught of fake news. Then the support for active and regular use of symptom self-screening by staff and communities with temperature monitoring. Certainly this would help with improving access of testing. Then also supporting staff during their quarantine while waiting results, especially helping them to manage their households, families, etc. And then the issues around, as we mentioned, food insecurity. This certainly needs to be addressed because people are not going to come for screening or testing if people are hungry. And then the integration and simplification of the tools. Our community care workers are now having to use 3 different types of tools for data collection, which is a bit ridiculous. And then GPS would certainly help if the phones that we were using apps that worked. And there's a great opportunity during COVID screening to also continue to screen for TB and HIV if we move towards saliva screening for COVID-19. Just in conclusion, yeah, the city of Cape Town is now the New York of South Africa, and this is really of concern, and this does raise the level of anxiety. We do definitely recognize that our healthcare workers are our greatest asset, and we certainly do need adequate PPE. The active case finding and the quarantining, contact tracing and isolation is certainly what needs to be focused on for now and in the foreseeable future. And certainly both the infected and affected households and patients need support. Our community care workers are certainly best placed to provide the foundation for a really strong public health response. And this needs to be supported by the rest of the health team and technology that works and is available. And again, TB and HIV should not be forgotten during this time. Thank you.
Thank you much, Ashraf. It's really great to hear from someone on the ground at the community level. So we're gonna move on with Wolfgang, who's a professor of virology at Stellenbosch University. Wolfgang.
Good afternoon, everybody. It's a great pleasure. And, you know, I was just thinking that 6 months ago, when Ashraf mentioned that Cape Town is the New York of South Africa, you know, I would have been very pleased. But of course, now we know this is meant in a different way. And it's sadly, it seems to be true. I'll briefly talk about testing approaches. Page down. There is a lot of guidance by WHO, particularly, and this is just the landing page from which a number of documents can be accessed. As often with WHO, it's not always clearly dated and named these documents, but on the whole, if you spend a little while with it, you will find a lot of useful guidance in there. The gold standard to come right to the point for diagnosing COVID-19 is clearly still nucleic acid or genome testing, also known as NAT. And this is the principle. So it's a respiratory specimen in the field. It's nasopharyngeal swab, and then RNA needs to be extracted from the fluid in which the swab is kept. And then the extracted RNA is reverse transcribed into DNA and amplified. And usually it's done on an instrument like depicted here in a real-time format. And then it can become either positive or negative. And there's a nice overview article of diagnostic testing here. Maybe we can make these articles available afterwards. There are a number of important considerations. And the first one is really that sample quality is key. So if the sample is not a good one, or it's not been stored adequately and there are delays in getting into the laboratory, then false negative results can occur. And that is clearly an issue, like with all tests, but particularly so here with tests that are not done on a standardized material like blood, which is basically always the same. That you can't really get that wrong, but here the quality of the swab is decisive, so it needs to be taken by somebody that is well trained and does it very carefully. And the other disadvantage of nucleic acid testing is that it requires sophisticated labs, it needs qualified and skilled staff, good facilities, backup power, and so on. And it needs expensive equipment and consumables. And all of these are, of course, scarce in much of Africa and in fact, everywhere. So these are the shortages. Another issue and challenge is the turnaround time. So sophisticated labs tend to be in the bigger cities. So the sample needs to get there, and then it needs to be tested, and the result needs to be issued. So that adds to the turnaround time. And the particular problem that we are seeing now, and we are not unique in that in the National Health Laboratory Service in South Africa, is that we really struggle to get reagents and test kits. Supplies are in high demand across the world. It's global competition, and those of you who followed how the United States are now scrambling to up their testing capacity can just imagine that, you know, there is stiff competition. And in addition, we are at the tip of Africa, and there is not that many planes coming in anymore. So transport links that used to be a daily simple thing have all been, been cut, and it's really difficult to get supplies back into the country. And we haven't found a solution to that, but we experience stock outs on a regular basis, sadly. And there are some promising options that are being evaluated as we speak. The saliva as an alternative sample type was already mentioned, and that would of course make the collection of samples much easier. It's more easy to standardize, and of course it would be better for the healthcare worker because you don't need to take that, don't need to be that careful. The infection risk is much lower. From the lab side, we are looking at simplified extraction procedures. That is another bottleneck, and possibly at pool testing. That said, in our own experience, as we have ramped up testing from less than 100 to 600 a day now, and that's 7 days a week in Tygerberg alone, our positivity rate has gone up from the single-digit figures to now about 1 in 3. That, of course, means that pooling is no longer an option. You won't be able to save reagents. Point of care nucleic acid testing assays are definitely an option, and this is the SARS-CoV-2 cartridge for the widely used Gene Expert. And of course, there are also considerations here. One is that TB testing must not be compromised, but from what we hear, the numbers of TB tests are already massively reduced, and I cannot but really worry about that because TB is not going to go away thanks to COVID. It will persist and it may not be diagnosed as readily as it was in the past. And the second issue is that supplies of these tests too are very limited despite the production being ramped up immensely. So a number of good molecular tests are available, and PharmD has taken on the job of compiling these tests and conducting evaluations. And this is again something which keeps changing basically from day to day. And it's very valuable, the type of information that one finds on these websites. And so far globally, it is estimated that more than 36 million tests have been performed for COVID-19, of which almost 10% were positive. So massive numbers for an agent that 4 months ago was not known. So I think that is a massive ramp up, and it is anything but easy. Of course, one needs to look at alternatives to nucleic acid testing that has these intrinsic issues and challenges. For example, testing for viral antigen instead of a viral genome. However, it has to be said that at this stage, it's clearly molecular testing that remains the recommended method and the gold standard. These viral antigen assays are being developed and are becoming available, but at that stage, one cannot recommend their use because their sensitivity so far does not equal that of nucleic acid testing. And they are particularly marketed as an easy point of care device, a lateral flow device, for example, which you could then use to test the respiratory samples from patients on and basically get a result within 15 minutes, similar to the point of care rapid HIV antibody test that many people know and use. So far, these tests cannot be recommended for routine use because their sensitivity is insufficient. You would have a high risk of creating false negative test results. But this is being done, so evaluations are happening, and I'm sure that development is ongoing. On a note of caution, however, I have to say that for other respiratory viruses like influenza and RSV, we have really abandoned antigen testing in favor of nucleic acid testing because it was of superior sensitivity. So I would be a bit surprised if for COVID we would find that antigen testing was able to stand up to nucleic acid assays. So what about antibody testing? So obviously specific antibodies are produced by the immune system in response to an antigenic stimulus, in this case, infection with the virus. And this is just a simple graph of the viral load going up in a patient who is experiencing acute infection, and then IgA and IgM and later IgG antibodies becoming available. But if you look at the timeline here at the bottom, you see there is an intrinsic delay, and that is a biological factor. This production of antibodies just takes time. So in the second week after onset of illness, antibodies are becoming detectable and may in future actually be a useful tool, but you will miss people during the first week or first 5 days of infection. And this is actually when we want to find them, because by that time they've already been infectious for 2 or 3 days prior to onset of symptoms. And so if we wait even longer to identify infected people, we will lose that window of opportunity to do contact tracing. So these tests are available and are being evaluated as we speak. And again, there is lab-based ones or point of care or rapid tests, again, mostly using the lateral flow principles. Usually these rapid tests have a lower sensitivity than the lab-based ones, which would basically mean here that the latency period until which before antibodies become detectable would be even longer than with a lab-based antibody test. So one has to be very careful, and there's a very strong marketing push now for these tests, but one has to really take that into account. And in the present situation, they may actually become a useful add-on, but they are not a replacement for swabs or nucleic acid. Particularly the point of care tests may in future become very useful tools, but we need to evaluate them very carefully in order to any mistakes there. And this is again happening. WHO, FIND, and also national bodies like the South African SAPRA are doing that now. And there are a number of questions that still need to be resolved. For example, do detectable antibodies signify immunity? We assume so, but we don't know for sure. We also don't know how long that immunity would last. We also don't know whether all patients that were infected with COVID-19 produce antibodies. And we need to be careful about possible cross-reactivity, which would then give rise to false positive results. For example, if somebody had a recent infection with another one of the human coronaviruses, would that perhaps stimulate antibodies that could cross-react with such a COVID test? So in the context of COVID-19, we currently are clearly in a position that antibody tests must not be used to diagnose suspected acute cases. But in future, once appropriately evaluated and shown to be a good test, these assays may be useful to diagnose the recent or remote past infections. So that is the people who we will not recognize by just looking for the virus in the respiratory secretions. For example, in outbreak investigations, the earlier cases, which you would miss by the swab sample, you could find and identify retrospectively, and thereby be able to reconstruct chains of transmission. And then for community surveillance and workplace surveillance, again, it helps to construct a more complete epidemiological assessment of the spread of SARS-CoV-2. So antibody tests are surely something we need to watch over the weeks and months to come, but any hype about them and their role is premature. We simply do not know enough about it, and the risk of making mistakes by basically certifying somebody to be positive and thereby be immune and not having a risk of becoming infected or transmitting the virus, the risks are very high. So one needs to be very careful as to how one uses these tests. Finally, a word about biosafety for laboratories, testing for COVID-19, but also, of course, testing for any other marker in patients with COVID-19. The only risk, luckily, from laboratory specimens would be from those from the upper and lower respiratory tract. They pose a potential lab biosafety risk, and for those, PPE should be worn, and that includes gloves and a lab coat and gown. And we have determined that respiratory tract samples, and in fact all of them, regardless of whether this is a suspect case or not, should only be pipetted inside a biosafety cabinet for the pre-analytical steps, that is before they become inactivated, to avoid any potential risk of contamination. And once that is done, everything else, so that would include antibody testing, but that also includes the majority of the steps for PCR, can be done under standard BSL-2 work practices, as are being used in biomedical laboratories in any case. If a biosafety cabinet is not available for pipetting the respiratory tract specimens, then face shields and respirators, the N95 respirators, should be worn by laboratory staff. But I have to say that from our own experience, the much bigger risk to laboratories these days, in Cape Town at least, the New York of Africa, is from staff members bringing in COVID infection from outside, to becoming infected in the community, perhaps sharing transport to and from work, or perhaps where they live, or perhaps from shopping, and then exposing others in the laboratories. And we've had that, and we've become extremely cautious about this. Of course, caring for our staff and wishing them to be fine, but particularly also because the quarantine period for everybody who's been exposed can absolutely sink our service. And this is why I'm now going to be putting back my mask and Preiser. Thank you very much.
Thank you very much, Wolfgang. That was very informative and interesting. So we're going to wrap up two small, talks, one from South Africa, one from Rwanda. So let's start with Hassan Mohammed. Introduce yourself, please. Hassan, can you put on slideshow mode?
Okay.
Thank you.
Thanks. My name is Hassan Mohammed. I'm a public health medicine specialist working with the Western Cape Department of Health. I also have an affiliation with Stellenbosch University. But just to say that I'm talking on behalf of quite a big contact tracing team from multiple universities and multiple organizations. So I do want to just acknowledge the role of a broader team in contributing to the work of this contact tracing team. I'm going to go fairly quickly because it'd be nice just to have some discussion. So I think just for the international audience, I'm showing where the Western Cape province is, which is in the bottom part of South Africa. Just briefly, our first case was on the 11th of March. And as of yesterday, we had 3,677 cases. And so there's obviously been a rapid growth, and we in an exponential growth period now in terms of our outbreak. The process in South Africa with respect to contact tracing is based on documents developed by the National Institute of Communicable Diseases. So that's our equivalent CDC. And it starts off with defining clear criteria for people who need to be tested. And these are referred to as PUIs, or persons under investigation. So when a person is identified for testing, if you look on the left-hand side, the immediate response is to isolate that person, collect the specimen, identify their contacts. And on the right is a brief definition of what we mean by close contact. So we use this as a guide, and of course it's just a guide. A person having face-to-face contact within 2 meters or was in a close environment with someone. So it's really household contacts, health workers who are in contact with a COVID case, or aircraft contacts, and that was actually important in the early part of the epidemic. So the guidelines said, gave us some idea about how to pursue contact tracing. We need to identify these close contacts, complete line lists, and ask the close contacts to self-quarantine for a period of 14 days from the exposure. And I think important just to emphasize that. To do daily temperature checks was what the plan was. And we would make contact with the contacts telephonically. So initially, there was a plan to keep in touch with contacts daily, but depending on the person, we would switch this to letting them self-monitor and then check in with them on an ad hoc basis to make sure that everything is in order. Quarantine, of course. How do we manage quarantine? Where should close contacts quarantine? And in general, we've recommended that it happen at home. And we describe that process for people, or where it's not possible to happen in a home environment, particularly now in our more poorer communities, there are designated facilities where people can quarantine. So cases can be moved outside for quarantine, or they can move, people who need quarantine can also be moved out. So what happens if someone develops symptoms? So one needs to have a process around that. So you monitor the close contacts, but if they develop symptoms, obviously they need to be, a sample needs to be collected, they need to be tested. If they're positive, they then need to be managed as a case, but if not, they then continue the quarantine period. And this just summarizes, it's a diagram, I'm not going to go through it in detail, describes the proposed contact tracing summary that we put together at the beginning of the outbreak. So in the Western Cape, what are we doing? We have an electronic method whereby we get notification of laboratory results. So we've got public and private sector laboratories who are conducting tests. There's an electronic notification process to a central point, and it gets uploaded into a database. So every day in the morning, when we come in, we'll see a list of new cases. Some of these are automatically inserted into our database, whereas others need to be captured. But all of this happens in an electronic way. So once we are aware of a case, we assign them to a team, a provincially based telephonic team who are made up mainly of volunteers. And that's been one of the interesting processes or aspects of our contact tracing, is that many people have volunteered to assist with contact tracing. And just in terms of telephonic volunteers, there's probably more than 50 to 100 and maybe 150 volunteers who participated in this process. We would telephonically contact the case, find out what's happened to them, isolate them, explain what isolation means, either in their home or offsite. We would find out what their contacts are, ensure that the contacts similarly isolate themselves in their homes, or arrange for that to be done offsite. Once we've completed that initial telephonic process, we then refer the case and contacts to field teams who then who do the monitoring for the 14-day period. Sometimes home visits are needed where it's difficult to contact someone, or where one needs to do a home-based assessment. So people at the local level who are familiar with a patient's home circumstances would do that kind of contact. And this perhaps overlaps with what Ashraf was saying earlier on. Workplace contacts, of course, there's been a lot of that in the Western Cape, so we need to engage with workplaces, and they need to do similarly contact tracing, isolation, quarantine in a workplace setting. And then in the initial phase, we contacted airlines and to determine airline contacts. If someone arrived from abroad and was found to be a case, we need to follow up the airline contacts as well. What about those who refuse to isolate or quarantine? So our legislation has provided for enforced quarantine or isolation if anyone does not adhere to that. So that's really a tool for us to use should anyone not be adhering to isolation or quarantine requirements. And it's been used in a few instances. It does require the authority of a magistrate. So one needs to go to a magistrate to get authority to enforce an isolation or quarantine order. So just some of the challenges. Ability to make contact with cases and contacts. Contact details are not always correct, and that's a challenge. Ability to isolate or quarantine in poor socioeconomic conditions. So we've tried to address that by creating or setting up alternative facilities where people can isolate or quarantine. Of course, adherence by cases and contacts to the isolation or quarantine requirements. And then we need to follow that up when we become aware of those particular situations. Language barriers, because we have a multicultural society, a multilingual society, and engaging with people about isolation and quarantine is a challenge when there are language barriers. And then, of course, we're dealing now with an increasing volume of cases and contacts. And to get to all of them timelessly is a challenge. And of course, we have off-site isolation facilities, but these have the limits. The last point I want to make is just to think about contact tracing as a chain. So I want to emphasize this particular point, and that is that in order for, we need to think about the goal of contact tracing. And the goal of contact tracing is to try and limit spread and to try and flatten the curve. And we've all heard about that. And it only works if the full chain is effective. And that chain starts with being able to identify cases, your surveillance mechanism, being able to conduct tests. Switch off your microphone, please. So being able to collect samples, so sample collection kits, having people to collect those samples. Those people need PPE in order to collect those samples. Once the samples are collected, they need to be processed by a lab. There needs to be a laboratory capacity to process these tests. And once the test is processed, you then need a team of people to do the contact tracing. So contact tracing is not just about the contact with the case and the contacts. It's really about the full chain. And if there's a break in that chain, then contact tracing is not effective. If there are delays at the laboratory, if we are not able to detect cases, if we are not able to collect samples, then we are not effectively able to achieve the goal of containment. And as we expand and as the epidemic grows, it becomes less and less easy to actually achieve the goal of containment. And that's a big challenge that we are dealing with at the moment, which is our ability to timeously and effectively achieve containment. We need to understand that once we achieve widespread community transmission, contact tracing is no longer effective and should not be continued. And that is as an epidemic expands, we move more and more to that situation where contact tracing is not a useful tool for containment, and one needs to focus on ensuring health system readiness to manage the cases that are going to be a burden on the health system. Thank you.
Thank you, Hassan. So quickly, Janine Kondo from the University of Rwanda, going to wrap up with a quick experience about contact tracing in Rwanda. Janine?
Thank you so much, Jean. Hassan, can you share the share screen? I think it's still on. Okay, now it's okay. 1 minute. Hello, everyone. Can you see the screen?
Not yet. So there is yeah.
1 minute. Can you see?
Put on slideshow mode. Yeah, thank you.
Thank you so much, everyone. And thank you, Jean. I think I'm honored to be here and to present and share the experience of Rwanda. Quickly, we are going to talk about what Rwanda is doing as a country to kind of, screen contact tracing, but also management of COVID-19. So this is a presentation that was made possible by my colleagues from RBC and Ministry of Health. As a background, so Rwanda first recorded a COVID-19 case in March 14th, 2020, and that was a resident from Rwanda coming from Mumbai. And since then, we did the detection, we did the test, and he was positive. A week after, there was a lockdown that was announced. That was on March 21st, and it was complete lockdown where all schools were, not operational. Public transport was stopped. Shops, everything was stopped. Only food and health were allowed, to allow people to go and seek those services. And this was a little bit intense. There were stringent measures, but also gave us good results. So I was asked to talk about the screening procedure. As I said, a week later, that command post was initiated, and both government and private sector were involved with more than 400 individuals, doing the screening, but also doing the contact tracing. We trained quickly doctors and medical students who were just finished the last year on how, we talked about sample collection, how to collect effectively the sample, because the rest becomes false negative or false positive if the samples are not well collected. So as a procedure, there was that initiation of command post that was working 24 hours, not only with Minister of Health, but also Minister of Local Governance, everyone went together and worked on that command center. So we activated surveillance at all districts about the signs, how to recognize the signs at all level, from central level to district hospital and even at the community level. In each district, because of the past experience of Ebola, each district has what we call, we call them the health team, to kind of help, informing quickly on any sign that anybody will have that is abnormal. For example, someone is bleeding. So we have that health team that were trained, using the FLTP program, and they're all deployed in all health facilities. And, not only that, having the people who are coming from outside, all of them were not only taking the temperature, but also we tested them on COVID, and to make sure that we don't have any case being imported, from abroad. On top of that, we went ahead and test all single employee who is working at the borders or ports of entries at the airport, immigration, flight crews, public places like banks, clubs, bars, everyone working there. We quickly take everyone and ask them if they can be part of the testing. They were actually happy because they were, they were working on the how we can minimize the cases in Rwanda. On top of everything that we did, to work on the resistance, especially on community, we worked very hardly on risk communication management as well as community engagement. So how did the Rwanda Minister of Health do that? They communicate the results through different channels, to Twitter, to television, to radio, and to local news later, to inform what are the strategies that are being put in place to protect the population. And that actually helped a lot in terms of, buying in the strategy put in place, especially the lockdown. So my next slide will talk about contact tracing. So, as many said, we usually have, when we have a suspected cases, given those criteria that we talked about, the truck drivers, the bars, the clubs, the immigration staff, airports, borders, and anyone coming from outside. That's where we started having our cases. And once we have a case, we test. Once the case is positive, the result is within 6 hours. And then we use, memory recall to kind of understand what were the cases or the contacts that the index case may have, been in touch, and we looked into definition of using within a meter as a space, but also the definition include the time, within 2 days and 14 days before the onset of the signs. And by doing that, we created a roster, and that roster was actually being managed within the command post to actually check on daily basis on the signs of all the rosters that we identify either within the household or wherever that person live. Something that I need to mention here, all the contacts that were very close in terms of space, distance, and also in terms of time were informed and systematically tested even before the signs are shown. And that actually helped us to mitigate, the impact of COVID in terms of the spread. Now, from that, what are the tools that we are using? We are using different tools for contact tracing. There were you know, first of all, we use in the past electronic integrated disease surveillance and response, EIDSR, that we used a lot in terms of the 13 public health conditions that were declared by WHO, but also for any signs, you know, that are abnormal. And those are the tools that are being used by community health workers, and all health facilities, including the district hospitals. Whenever they see a suspicion, they will get information on EIDSR, and everyone on the channel, including the minister, will, if you want to, will see what is happening at any point in country. And then, you know, we use also Welltel in the past couple of months as a tool for contact tracing. Again, you know, the issues with all these systems is the integration of all these systems to one. So right now, Rwanda is working so hard with different partners, you know, to integrate all the system within the HIS or, you know, to see how we can have one platform that will not only collect information, but also manage the patient. So in the hospital space, we are using OpenMRIs to manage, you know, in terms of treatment, but also lab tests. So just a quickly update. So right now, that was yesterday, we had a total 35,000, almost 36,000 tests done so far since the first case appeared in Rwanda, that was diagnosed in Rwanda. That was on March 14th. And we had total cases that were confirmed, 261. We have recovered around 129, which is almost 50%. And so far, we're lucky, or probably those stringent measures, we had recorded 0 deaths. I'll end this presentation by the slide that is really promising in terms of death recorded, which is 0. Thank you. Over to you.
Excellent. Thank you, Janine. Fatima, up to you. We're going to probably extend 10 or 15 minutes. Fatima?
Thank you, Jean. There's a number of questions for the different speakers, so I'm going to ask one each for each one of them and then go to the others. So, Ashraf, for you, did your CHWs do daily self-symptom reporting, and did they do this as manually or via an app? And was this, if they did use an app, was it your own app?
Yeah, so we've developed an app through RedCap software, and yes, it's done now electronically. It's uploaded onto the phone, and it's very easy to use. So, and that information gets automatically centralized, fed to their various managers, who will then revert back to that staff. So yes, it's all electronic.
Is it open source? I'm sure somebody's going to ask me that.
Yeah,
if it's open.
It is open source, and we'd be happy to share that.
Perfect, thank you. Wolfgang, given the reports that coronavirus VL is higher in saliva than NP swab, I think you mentioned this in your presentation, is consideration being given to saliva testing?
Absolutely, yeah. I think we are one of many labs trying this out. And, you know, it would have immense advantages, I think, in the pre-analytical phase. So it would be much easier for the community health workers to request saliva samples. So, you know, less unpleasant for those being sampled. So we think this would be a great step forward. Unfortunately, it's probably not going to lighten our workload in the lab. But for that, we are looking at these other options of you know, improving our workflow and making it quicker and less dependent on consumables, which will work to some degree. But saliva testing, there are several papers, but you know, everything is happening so fast in COVID that one needs to be quite careful, because these are all very early reports, and they have normally not been confirmed by subsequent, you know, not been peer reviewed often, and not being confirmed by subsequent studies. So we need to do that, but this is happening.
Thank you, Wolfgang. Hassan, the question to you was, what is the tipping point to stop tracking and tracing given the resources required?
Now, thanks, Fatima. That's not an easy question to answer. And if one looks at this from a provincial perspective, clearly in rural parts of the province, we have lower numbers, or there are some places where there are no cases. And clearly, contact tracing and active contact tracing and management should continue there. But within the Cape Town Metro, the Cape Town area, which is quite an integrated space, it's very difficult to judge at what point, you know, we should stop. The disease is not uniformly spread throughout the city. It's now come to be mainly in the poorer parts of the city. But does one start saying, is there a number that one uses? We haven't come across a number. We are debating this on an ongoing basis as to at what point we need to stop contact tracing. But I think that question will be determined really mainly by resources. As our epidemic escalates and when we reach a point where testing resources are used mainly for severe cases, we will just simply just not have the capacity to test people who have milder disease. And that's the point at which we will have limited contact tracing. So it's, I think, not a number answer, but it's more a resource answer. Thanks.
Thanks, Hassan. Janine, this for you and for somebody who's also in the Cape Town area. Is there anything about pets protection in Rwanda and Cape Town?
I'll attempt to answer that. I don't think there's much evidence, and others can comment on this, that pets are at risk. So there's no specific requirements, as I understand it, for the protection of pets. Thanks.
Thank you, Hassan. Okay, Ashraf, there's another one about, is there a difference in community level incident versus targeted incidence testing?
I think Hassan is better placed to answer that, but from my feedback, certainly the targeted testing is much higher yield than from the community testing. The yield from the community testing has not been as great as we'd expected. Hassan, over to you.
Yeah, and I can also add to that. I mean, I think the Western Cape's chosen a particular strategy in terms of testing and to test around cases, and also in terms of workplace clusters. And the yield has been very high, particularly from workplace clusters, not as much from community screening, but certainly when we target testing around cases, the yield is higher. So community incidence is difficult to use as a guide, in the sense that there's a lot of variation within communities. And when one looks at the epidemic that we've had, which shows a high prevalence in workplaces, what we see in communities is a reflection of what's happening in workplaces. And the interesting pattern that we're seeing in the Western Cape are those services that were allowed to continue to work under lockdown. So similarly, those food places, security services, etc., that's where we found a lot of cases and clusters happening. And many of those people come from the poorest communities of Cape Town. So although we see a community incidence, the incident or the case of transmission more often than not would have occurred in a workplace setting rather than necessarily from your next door neighbor. Thanks.
Thanks. We have a number of questions, but I'm going to try and get to at least 2 or 3 of them because I'm sitting with more than 6 at the moment. Wolfgang, what is the effect of delayed return of results? If quickly we can get that in a minute or 2.
Yeah, I mean, it really depends, and actually we are tackling this now. The issue is at the lab phase. You know, it's difficult to distinguish for us whether these samples are now from inpatients, where important critical decisions are based on the test result, or whether they are from community screening, which is not that urgent. So obviously, the sooner we have the result, the better. And I think this is also the allure of the point of care assays. So at the moment, we are hoping, but we don't have the reagents yet, but we are hoping to be able to fast track those particularly urgent samples using the Gene Expert, which gives you a test result within 1 hour, and that includes all the different laboratory steps. And then use the high throughput platforms and tests for the other samples. That would definitely help. But again, the problem is that the supplies of the kits really vary, and very often you run out of the one or the other, and then you just have to use whatever is available. If it goes beyond 2 or 3 working days, one really has a problem, because this is a very fast-moving disease, short incubation period, as little as 2 days. Then people are infectious prior to onset of symptoms. So, if you don't get a times result back, you really have a window of opportunity which closes very rapidly.
Thank you, Wolfgang. We're still getting questions. I'm going to do 2 more, and whoever else has not been answered, we will try and get responses back to everyone. One of the ones that I will leave open to any of you to answer is, are the field workers offering counseling to the identified cases? And what also is being done to reduce stigma from community members once they see the field terms are making constant visits during the 14 days of isolation? Does anybody want to take that?
I'll step in, Fatima. I'm happy to speak about both issues. And what we found with the telephone contact tracing process is that, particularly early in the epidemic, when someone's given their diagnosis, it's a shock. So there's definitely a counseling process that's required, and sometimes a 2-step process where you'd have more than one telephone call, talking someone through the process, getting them to understand what it's about. So again, I guess I can say a lot more about that, but counseling is very much part of it, and this is going to be a challenge with electronic systems. An SMS with your result doesn't counsel you. And we feel it's important from an education point of view, from a stigma point of view, to address it by person-to-person contact. So stigma, we've also encountered that, particularly in the poorer areas of Cape Town. Threats of violence, threats of eviction have certainly been part of it. I think the province has tried to be proactive in terms of education campaigns and to educate communities. So we have, via various media, tried to address that. But it's something I feel could have been done stronger, more intensely from the start of the epidemic. Thanks.
Thanks, Hassan.
Can I add something there, Fatima, just to reiterate the value then of your community healthcare workers in really providing the information. So really at the beginning of the epidemic, what really helped in addressing stigma, personal stigma, was in fact to support the households. And this is where the patient advocates or the community healthcare workers really helped these households address all the barriers to adherence and understanding the disease. And the same principles can now be applied to COVID-19, especially during isolation and even post-disease. Now that the numbers of HIV have risen to a level that it is quite common, that level of stigma has reduced significantly. And I'm sure that's the best approach we can use then to address this fear that people have, and that what generates the stigma and the discrimination that we find, and the xenophobia that we find with these new threats. So it really is going back to basics, making sure, as Hassan is saying, that form of interpersonal support and encouragement and addressing of these issues is really on tap, is available. Otherwise, it's just going to create problems as we go along. And this will certainly be exacerbated by the lack of food or food security, as we've seen in the Cape, where there have been stores ransacked, where people have been wanting to get access to food. Thanks.
Thanks, Ashraf. I have one question for Rwanda, but before I do so, everybody also wants to know whether the slides will be shared. So we may ask your permission to be able to share the slides on the AFREhealth website, if that's okay, along with the recording of this webinar. So we'll do that electronically. But Janine, there was a question for the Rwanda team. You managed to identify COVID-19 cases in the early phase of the infection. However, I would like to have a brief summary of the medical management that might have contributed to the impressive successful rate of recovery?
Thank you so much. I think what we did was that really extensive work around COVID. So everything was almost stopped, you know. So first we created satellite sites for managing COVID. So far we have 3 big satellite sites. For example, health center that was not really well used, you know, or not used 100%. So with few beds, we try to manage everything on site. So there was no isolation of COVID case at home. That option was not there. So once you are detected positive, we'll bring you to the isolation, isolation center, and we treat you and make sure that you recovered from all that. Second, the population in Africa is quite young. So, you know, the average of people who got COVID, it's, you know, between 35 and probably 40 years. And we didn't have a lot of cases with complications, including hypertension or diabetes, and so those are very, very, very young and active people who travel a lot, who got the disease. Most of them, were coming from abroad, and few of them are, the truck drivers, especially the last days. We receive, like a huge number of drivers, across the regions, with the COVID positive cases. So I guess we didn't have any window of contamination within the household once we knew that you are COVID positive. And plus we'll do those monitoring of signs, but those who are really close to the case, the index case, will go, not waiting for the sign, will go and test everyone living in that household, or even in the same compound if they're sharing a compound. So I guess those stringent measures actually helped reduce the contamination within the population. On top of that, all public transport, motorcycles, everything was stopped for those 3 weeks, 4 weeks of complete lockdown, and that helped us actually to manage well the cases. And yeah.
Did you use any specific pharmacological treatment that was not indicated for COVID? Is, I think, what everybody wants to know in that medical management. Did you use normal, just sort of supportive therapy, or did you try something new?
No, we did normal therapy. I can share the management of COVID later on within my slide.
Perfect. Thank you.
Yeah.
I think that's what everybody wanted. I'd love to go on more. I have something like 12 questions here. Unfortunately, we've run out of time, Jean. So I think we'll do the same thing. We will try and answer these questions via the AFREhealth blog or discussion group. So please sign up to be a member or part of that. And we will have hopefully a recording of this webinar on the website as well. I'll hand over to you now, Jean.
Yeah, thank you, everyone. Just to thank all the speakers for the terrific really talks, and to our board, but also all participants across Africa, United States, and also Europe. It's been a really great experience of sharing. So thank you, everyone. And keep safe.
Thank you.
Thank you.
Thank you.